start the recording first. I hope I have started the recording. Okay. I hope you people can see my screen, so I'll be able to swap it here and there, and then I'll be able to move forward. Okay. Bismillah Rahman Rahim. So lithium in psychiatry. As I was mentioned earlier, that lithium is the most oldest drug that is prescribed. The history of lithium is very surprising and strange. There was a lake in US, probably somewhere in Pennsylvania. I don't remember the name of the place. That lake was famous that most of the people who drink water from that lake, they are cured of their arthritis and other ailments. They feel happy and they were feeling very good about it. So the assessment of the water in that lake was done, and it was found that it was having high content of lithium in that water, and people started feeling good by drinking the water. So then lithium was promoted as a drug which can make you happier. It was given, that water was actually given in commercially to people who were suffering from various kind of disorders, arthritis, pain, mood symptoms, and all that stuff. And it was getting popular. It was so popular that they started marketing this water just like you get a mineral water in your home to drink regularly. So they started promoting lithium water in markets, and people were drinking it and they were feeling good about it. And then it was again very popular. So even there was a lithium cola, so it was added into the fizzy drinks available in the market at that time as well, back in early 1900s. And then it was suddenly seen that the people who were having this water or lithium cola and all those drinks, they started having some urinary problems. Some of them actually died of urinary problems, renal failures and all that stuff. So then gradually it fizzled out. And then again, the research was conducted to see what was there in that water that was making people comfortable and how it can be addressed, that it should be given in an appropriate amount so that people will keep on feeling good and they won't get the toxic side effects. So lots of research was carried out on that water and lithium, and it's been in the market for more than 125 years or so, maybe more than that, maybe less than that, but almost a century. So lithium is a good drug, long-standing in psychiatry, given for various purposes. And as I told you about the history, this is again very significant how lithium came in. Usually, we always see that lithium is given in bipolar disorders. Now, bipolar 1 or bipolar 2, but in bipolar, clinical features are neuropsychiatric, increased activity or energy, altered circadian rhythms. Then there are mitochondrial dysfunction. There are ESR, stress response. There are some situations related to autophagy, decreased and then cellular response to counteract damage and increased survival, glutamate hyperexcitability as well. So lots of theories have been postulated related to bipolar disorders, and more research is coming up, demarcating various forms of bipolar disorders, what is actually the problem in bipolar disorders and how you should treat it. And mood stabilizer, out of all the mood stabilizers, the long-standing treatment with lithium is still one of the most commonly acceptable strategies by most of the psychiatrists across the globe. This is what it is. And we know that in bipolar disorders, there is mania, there is depression, mood stabilizers have their role. Now, the pharmaceutical companies are promoting many antipsychotic medications, new antipsychotic medications, and they say that they act as a mood stabilizer in bipolar disorders. However, anti-epileptics, lithium, lifestyle modification, psychotherapy, all of these have a role to play. Now, when we talk about lithium, and as I mentioned to you, that lithium is basically an ion, which is actually in periodic table, it is at number 3. So it's a lightweight element in the same group where all other metals are. And we know that over the period of time that sodium is one of the metal which is present in the body in the form of sodium ions, sodium channels, sodium chloride, blah, blah, blah. And old books, well, rather, most of the books, and I've been taught this as well, that lithium displaces sodium and then it have a membrane stabilizing effect, which gives you a mood stabilizing effect. Actually, it is not as simple as what I'm saying this. It's more complex, more complicated, and you won't be able to find an MCQ which will be just telling you this kind of a thing, because this is an old concept. The new concept is very, very different. So let's start with some of the things. I probably you people don't know that lithium is one of the strategies where you can prescribe it in people suffering from dementia, because it is seen that the lithium improves the verbal and non-verbal memory. It also improves executive functioning, processing speed, and working memory. And all of these things have an effect on the mood as well. So number of manic depressive episodes, remission versus acute episode, and manic polarity. These are some of the things where you can prescribe lithium. So if you come across with some prescription of a person who is an adult, of course, and he's been given lithium and he is having intellectual disability, don't get surprised, because there were some studies conducted in mid 2000s as well, where they felt that lithium can improve the memory. Although not significant effect is there and not significant evidence is there, but people do prescribe it in dementia, intellectual disability, in people who are having memory problems, in people having memory problems in depressive disorders, bipolar disorders, manic disorders. Lithium is prescribed in other indications as well. So remember that lithium is one of the ion which helps in promoting verbal, non-verbal memory, executive functions, processing speed, and working memory as well. Although, again, I don't prescribe it in people with dementia and intellectual disability, but some people do that. I won't recommend it actually because the data is limited. They say that the lithium promotes GABAergic neurotransmission. So in presynaptic neurons, when lithium goes there, it has both the effects at presynaptic neurons and postsynaptic neurons at the GABA receptors, and it increases the GABA levels in CSF. Presynaptic, it facilitates GABA release, and postsynaptic, it upregulates GABA B receptors. Now, GABA receptors and bipolar disorders, you will be surprised because they are two different phenomena. But this is one of the mechanism of action of lithium. So if you get an MCQ that what is the role of lithium on GABA receptors, this is one of the things. It increases GABA levels in CSF. At presynaptic level, it facilitates GABA release, and at postsynaptic level, it upregulates GABA B receptors. Then furthermore, lithium downregulates NMDA receptor. And again, as you might be knowing that there are few drugs used in dementia which are NMDA receptor antagonist or something like that. So this is another mode of action of lithium. that lithium actually have NMDA receptor, glutamate receptor effect. Glutamate is excitatory neurotransmitters elevated during mania. So this is one of the theories that lithium actually regulates NMDA receptors and glutamate and helps in improvement in mood state, especially during mania. This is another one of the MCQs probably at FCPS Part 2 level. You can expect that as well. What is the effect of lithium on NMDA receptors? It actually down-regulates NMDA receptors. Lithium inhibits IPP phase and IM phase. Now, what are these? Uh, if it's getting too much complicated, please stop me and do ask me question if you want to. So what lithium does is it has an impact on IM phase and IP phase. These are the phosphoinositide cycle. It have an impact on that cycle. So phosphoinositides, precursor of signaling molecules, an enzyme IPase and IPase synthesis of myoinositol. Lithium is a monooxidase inhibitor and depletion hypothesis. So it affects these two enzymes in the phosphoinositide cycle, which in turn affects the body metabolism and mood regulation indirectly. So this is another MCQ which is expected, that what is the effect of lithium on IPase and IMPase. So lithium inhibits both of them. Now, this probably you won't be able to understand it unless or until you know the whole of the cycle of phosphoinositide cycle, which I probably won't be able to teach you here, but definitely if you people are interested, we will cover that sometime. Lithium inhibits PKC, MARX, and GSK3. Have you ever heard of these things? Question. Anybody?
No, sir.
No, sir,
Sorry,
first.
no.
Okay, so this means that we are going at the right pace so that you will be able to understand what I'm talking about. So lithium inhibits PKC, MARX, and GSK3. When I was teaching you earlier, it downregulates NMDA receptors. It inhibits IPase and IMPase. It inhibits PKC, MARX, and GSK3. Now, lithium inhibits or stop GSK3, which is glycogen synthetase kinase 3. So you might have heard about glycogen synthetase, which is an enzyme system, and one of its form is kinase 3, and lithium inhibits it. And when it inhibits GSK3, it has an impact on, again, whole of the metabolic cycle related to it, which includes other enzyme systems in the body as well. And in turn, lithium gives a gene transcription, synaptic plasticity, activated under conditions of chronic stress. So there was a hypothesis that people who are suffering from bipolar disorders, they remain under some kind of a stressful state and their mood is not actually stabilized because of some fluctuation in the stress phase. So sometimes when the stress is more, they get depressed, and their stress is less, they get manic. So there are multiple theories related to it. For you people, it is important to know that if there is an MCQ, what is the role of lithium on GSK3, which is glycogen synthetase kinase? It says that lithium inhibits PKC, MARX, and GSK3. So lithium has a role on NMDA, lithium has a role on PKC, MARX, and GSK3, and lithium has a role in IPP phase and IM phase, enzyme systems of generally thing. Now, this is a common thing which is available in the literature, in the books that you people are reading most of the time, that lithium attenuates calcium influx after activation of NMDA receptors. So primary action of lithium is on NMDA, and NMDA in turns, when it activates, it actually reduces the effect of calcium influx into the cell, which reduces the excitotoxicity via modulation of calcium entry and inhibition of calpain pathways, which is protease that plays a role in apoptosis. Now, forget about this, it's too complicated. I was not able to understand it completely as well. But in nutshell, lithium has an effect on NMDA receptor, which has an effect on calcium influx, which actually helps in excitotoxicity via modulation of calcium entry. This is important. So if there is an MCQ in your FCPS exam related to lithium and effect on calcium, you will say that lithium attenuates calcium influx after activation of NMDA receptors. Now, because most of the exams are now converting into MCQs, especially FCPS Part 2 as well, and if there is a question on lithium, some questions will be related like this. So you must be able to understand that. We all know that lithium helps in controlling both the bipolar disorders phases. In mania, we have to maintain the higher levels. In depression, we have to maintain relatively lower levels. And in cyclothymia or rapid cyclers or other forms of mood irregularities like in borderline personality disorders, there is mood irregulation, and there are some studies which indicates that the lithium can promote impulsivity and mood fluctuations in borderline personality disorders as well. But again, I am not recommending it. I am telling you that there are some studies available related to it. So you can prescribe lithium to people with borderline personality disorders having extreme fluctuations of mood and impulsivity. So mood incongruent psychotic features, residual symptoms between episodes, and psychiatric morbidity. So these are again more indications of lithium. So lithium now is indicated in mood disorders, borderline personality disorders, dementia, have an effect on memory, intellectual disability, blah, blah. So the way we are processing it, this is the way you can generate the indications of lithium as well. And lithium actually reduces the risk of suicide in people who are having either the mood disorders or any other disorders. So lithium is given an augmentation strategy in resistant schizophrenia. Lithium is given as an augmentation strategy in unipolar depression where you are not getting an appropriate response from routine medications. Lithium is given to other people in other situations as well. I hope you are able to understand this. Can you make sense out of it? समझ आ रही है कि नहीं?
Yes, sir.
Okay, okay. Just keep listening, and if you have any questions, I will definitely answer. So now they say that the lithium has neuroprotective effects. What does it do? In bipolar disorders, it increases the GSK3, which I have already told you. It increases the BDNF. It increases the autophagy, which we mentioned very briefly in the previous slides. It reduces the TNF and TBARS. In Alzheimer's disease, it again has effect on GSK3, BDNF, tau protein is reduced, autophagy is increased. There are other mechanisms where lithium can reduce the inflammation in people having Alzheimer's disease. One of the hypotheses. Then amyotropic lateral sclerosis. There is a physical indication of lithium where it increases the GSK3, p-tau is reduced, and autophagy is increased. In Parkinson's disease, now this is surprising. Most of the people say that lithium should not be prescribed when people are having tremors. Now, yes, if people are having tremors related to some pathology related to endocrine systems, then lithium usually should be given carefully because lithium, one of the lithium side effect is tremors. But people with Parkinson's disease not responding to usual anti-Parkinsonian drugs, you can try lithium because it will have an effect on GSK3, BDNF, tau proteins, and autophagy as well. So this is another indication added into the list. So, phase of illness, mania, depression, rapid cycling, and lithium is the drug of choice. You add atypical antipsychotic as a second line, but the first line is lithium. First line is lithium in all the three phases of bipolar disorders, but you can add antidepressant, antipsychotic, or other mood stabilizers in resistant cases as well. So that is another way of moving forward. Indication in bipolar disorders, I don't have to go into the detail. Most of you probably will know that the target is to achieve the serum lithium levels of 0.6 to 1 milliequivalents per liter. Level timings should be done 12 hours after the ingestion of the last dose. So if the person has taken the last dose of lithium at 8 p.m., the blood levels for the serum lithium levels should be checked at 8 a.m. in the morning. 12 hours gap is essential. Now, why is it essential? And it is done on the 7th or 8th day of lithium therapy because the steady state is achieved in 7 to 8 days. So when you prescribe lithium to somebody, the levels won't be good enough if the levels are done on 2nd, 3rd, 4th, or 5th, or 6th days. So lithium goes into the system. It has a peak level suddenly achieved because it's an ion. It is safe in liver diseases because it has no metabolic pathways related to the liver. So it is absorbed from the gut. It goes straight into the blood levels and it achieves sudden peak in its levels in the blood. Then the levels drop because it is distributed intracellularly and there is a drop in the levels, and then the drop goes up as well. So when lithium occupies intracellular spaces, it is again going up. The levels go up and then a steady state is achieved. Now this biphasic increase in lithium levels in the blood during the first week of treatment is usually complicated. So why do you get the blood work done at 7th stage? It's because of this biphasic increase in the serum lithium levels to achieve a steady state, which is achieved in 7 days. Another MCQ, if probably you'll be able to get it. Toxic levels, mild 1 to 1.5, moderate 1.6 to 2.5, severe 2.5 or more. Toxicity symptoms, we will talk more about it. Common side effects is acne, cardiovascular problem, xerostomia, polydipsia, polyuria, and in some cases, weight gain. Not all the cases of weight gain, but we will talk about the side effects more. As I mentioned to you in the beginning, that what are the contraindications of the lithium therapy? Uh, Contraindications should especially be monitored in patients with renal disease. You cannot prescribe lithium with people having compromised EGFR. This means that most of the lithium is actually excreted through the kidneys. And because passes through the renal tubular system, it can have an effect on renal clearance and the kidneys may be damaged. So people who are having compromised kidney states should not be given lithium at all. This means that prior to initiation of lithium therapy, you should absolutely work on making sure that the person is having absolutely no renal disease. Then cardiac disease, as it is an ion and it suddenly goes inside the body without going through the liver system. So it has an effect on conduction defects of the heart. So if a person is having some conduction problems, because of that, lithium can cause cardiac problems. So you have to rule that out. Get a simple ECG and serum electrolytes level. And if they both the things are normal, then you can prescribe lithium with no problems at all. If people are dehydrated or places where it's too much cold and people don't drink enough water, the lithium should be prescribed with carefully. And again, contraindication is pregnancy and breastfeeding, because lithium is an ion. It goes into the breast milk completely and it is excreted through the breast milk. So they go into high levels in the child and infants, and the levels which are appropriate for a young mother probably will be very toxic for the infant. So that is one of the reasons why it is contraindicated in breastfeeding. So absolute contraindication: renal disease, cardiac disease, dehydration, pregnancy, and breastfeeding. 5 contraindications. You should not prescribe lithium. How does lithium affect the thyroid? Now, people say that some of the people who are taking lithium, they develop hypothyroidism, which is again unfortunately true. So it increases the iodine content in the thyroid gland. It reduces the thyroid gland's ability to produce T4 and T3. So if there is an MCQ, how lithium affects the thyroid, these are the two basic mechanisms. One, it increases iodine content in the thyroid gland, and it reduces thyroid gland ability to produce T3 and T4. It blocks the release of hormones from thyroid gland and alters structure of protein thyroglobulin. How it alters the structure of protein thyroglobulin is through G whatever GS3, whatever I told you earlier, right? So on thyroid, iodine is more, increases iodine content. The processing is slower because the thyroid gland is not able to produce enough T4 and T3. Person goes into hypothyroidism. It blocks the hormones and it affects the thyroglobulin protein as well, which carries those hormones across the body. Acute and acute on chronic intoxication of the kidneys, of the lithium. Most of the people, when they take lithium carbonate, as it is a salt, it can give them disturbed stomach, nausea, vomiting, diarrhea. I've been prescribing lithium for past 30 years and I saw only one person who complains about it. So on an average, if I believe that I have given lithium to 1,000 people, maybe only one developed these side effects. So it's a tendency to develop these side effects is very low. Cardiac symptoms, if the ECG changes are not there, then arrhythmias, prolonged QTC intervals, and bradycardia could be a cause. So people who are already having bradycardia, if you prescribe them lithium, they will have lower, again, pulse rate, lower heart rate, and they will complain of some drowsiness, dizziness, or sedative effects with lithium. So if a person comes to you that I've been given lithium and I am sedated or slow or lethargic, then you must understand that this could be related to the side effect of the lithium on heart. Neurological symptoms. They usually are developed late, but syndrome of irreversible lithium affectuated neurotoxicity, which is called, say, silent, uh, inappropriate ADH, antidiuretic hormone problems are caused by lithium. Chronic intoxication, gradually developing sluggishness, ataxia, confusion, agitation, tremor. Cardiac side effects, acute and chronic, which could be because of intoxication, and renal side effects. So these are some of the side effects of lithium therapy. Mild side effects includes sleepiness, paroxysmal muscle weakness, impaired memory, nausea, vomiting, diarrhea, delirium, convulsions, coma, hyperreflexia, fasciculation, Parkinson's-like symptoms, ataxia, incoordination, nephrotoxic nocturia, distal tubular acidosis, impaired kidney functions, flat T wave, hypotension, and less CNS depression. I hope they are not too much for you. But to simplify it, to simplify it, there is a scale which is used for lithium toxicity assessment. It is called MDSEN rating scale for the assessment of lithium toxicity 0, 1, 2, 3. Very simple scale. No clinical signs or symptoms is 0. 1, mild, including nausea, vomiting, tremor, hyperreflexia, agitation, weakness, and ataxia. 2, moderate, including stupor, rigidity, hypertonia, and hypotension. Severe is myoclonus, cardiovascular collapse, seizure, and coma. Okay, so Manur, you have given some picture on the message box. What is that?
Sir, I just took a snapshot of the slide.
Okay, okay. I thought you were asking some question. So stop me if you want to ask a question. This is a simple scale, MDSEN lithium rating scale for toxicity 0, 1, 2, 3. All the side effects of lithium are mentioned here. And I honestly tell you that over 30 years, I have been prescribing lithium for people, and I haven't seen any person who is having 2 to 3, very few. So one of my patients developed a seizure after lithium therapy. One of my patients developed hypertension with lithium toxicity. But these are very few. And of course, any drug can cause any problem. So we have to be vigilant and careful in monitoring the drugs. But this never means that we should not prescribe. All of these side effects are relatively less. So don't bother about them in day-to-day clinical practice, but be vigilant. If you don't know, then you won't be able to assess. What happens if the lithium toxicity occurs? So you come across with a patient who is already having lithium toxicity. What should you do? Same strategies in the exam. You have to tell them this in the same way. ABC, airway, breathing, circulation. Hydration, maximize lithium clearance. So you give a saline replacing lithium with sodium chloride. And GIT, again, if you need, you just have to make sure that it is irrigated with polyethylene glycol solution in large or acute ingestion of sustained release preparations 2 to 4 hours after ingestion, not afterwards. So the best strategy is ABC and hydration. Now, in textbooks, well, I never came across with this kind of a situation where I have to go for hemodialysis in patients with lithium toxicity. But yes, theoretically, it is asked, and you should know that when lithium levels are more than 4 in patients, you should try to go and think about hemodialysis. Renal insufficiency, severe intoxication, contraindication or aggression, fluid hydration, or heart failure, you should go for hemodialysis. More than 4, I haven't seen a patient who is having more than 4. But if the serum toxic levels are 4 or more, immediately goes for hemodialysis. If the levels are 2.5 and physically affecting the body, then you should go for hemodialysis. If the levels are less than 2.5, but the signs of intoxication, these ones, myoclonus, cardiovascular, collapse, or seizures, or coma, then go for hemodialysis. But other than that, you don't need to. And when we are talking about high lithium levels, of course, the lithium levels vary from person to person. Some people achieve good therapeutic levels on 400 to 800 milligrams per day. Some people achieve good levels on 1200 milligrams per day. So the dose range is anything between 300 to actually 12 to 1500 milligrams per day. And with this dosage range, most of the people, they don't develop toxic levels. Most of the people. Exceptions are always there, but this is how you have to manage. So lithium toxicity side effects. Mnemonic is lithium. Lithium is lithium. L for leukocytosis. I for increased urine output, polyuria. T for tremors and thirst. H for hypothyroidism. I for increased weight gain. U for upset stomach and diarrhea. And M for muscle weakness and mental issues. So lithium side effects is lithium mnemonic. Leukocytosis, urine output, tremors, hypothyroidism, increased weight gain, upset stomach, and muscle weakness. I hope you will remember this in the exam as well. And adverse effect management, as I told you earlier, you have to assess the person, make sure that you are consulting with nephrology, the parathyroid and thyroid glands are assessed properly, neurological examination is conducted, and GI system is cleared up. This is important. Hypothyroidism and hyperparathyroidism. So lithium can cause hypothyroidism and hyperparathyroidism. Hyperparathyroidism because of its effect on anybody.
सर
Anybody.
जो उसका जो कैल्शियम के साथ जो इसका
Exactly.
रिलेशन है उसकी बता
So
सकते
effect on the calcium, it actually attenuates calcium intake. So that effect is basically because of glycogen synthetase kinase 3B, GSK3B, which in turn speeds up production of parathyroid hormone. So it can cause hyperparathyroidism and hypoparathyroidism. Both are, again, should be understandable. And yes, you are right. GSK3 inhibition of calcium effect on parathyroid hormone, increased production. Right? Okay, practice points. Now the practice points are, whenever you want to start a lithium, make sure that the person's thyroid profile is done. Make sure that his renal status is done. Make sure the cardiac status and the ECG is done. Make sure that the CBC and urine examination is done to make sure that the renal system and general leukocytosis is not there. If that it's there, then be careful about it. So leukocytosis nahi hai, urine examination is clear, cardiac abnormalities are not seen, and again, so 5 tests: thyroid. We usually don't go for parathyroid hormone, but if you are very enthusiastic, you can check it out. And if the function is normal, then of course you can repeat it in a 1 year time and see if there is any effect on hyperparathyroidism or not. But usually it's not done because that is the phenomena which will occur after lithium will start giving the side effects otherwise. So it's much before that you will be able to pick up that this person is developing the side effects with lithium. So monitor vital signs, order laboratory testing of blood counts, renal function, lithium levels, time routinely for any patient who's taking lithium. Now the levels are done usually 7 days after the initiation of therapy. And then afterwards, they are done once every 2 weeks for 3 months, then monthly for 3 months, and then you can go for 3 monthly for the rest of the time till the time the lithium therapy is continued. But the blood work and the laboratory investigations like cardiac profile, the renal profile, the CBC, the thyroid, they can be done once every 3 months initially, and afterwards they can be done once every 6 months to a year, whatever you feel is appropriate. Consider patients about the possibility, counsel the patients about the possibility of the side effects, the bradycardia, the myoclonus, the sedation, the gait disturbances, which are probably could be because of the lithium. Also get the ECG, lithium levels, and cardiac history if the patient is more than 40 years of age. Monitoring the patients who are taking lithium is important. Serum lithium levels should usually be measured 3 times weekly, and blood studies and urine analysis performed weekly during the initial period of drug administration as required thereafter. Now, this is usually done in inpatient psychiatry. Outpatient psychiatry, you don't have to do so many because in outpatient psychiatry, you will push up the dosage of the lithium very slowly. So you will start 200 milligrams, half a tablet for a week, get the serum lithium levels, push it up to 400, 600, 800, stop there, see how things are. If the mood symptoms are getting better, of course, then nothing needs to be done. But if you want to achieve high levels of lithium and the patient is in inpatient psychiatry and he's having acute mania, then of course you will give a bolus dose, 400 milligrams today, tomorrow 800 milligrams. Maybe next day you will push it up to 1200 milligrams per day because you want to achieve the serum lithium levels of 0.8 to 1.2 and get the serum lithium levels. If they are 0.8 to 1 in acute mania, they will work best. If they are less, probably the acute manic symptoms won't be a good, again, choice of treatment with lithium. Maintenance 0.6 to 1 millimoles per liter. Usually I'm very happy if the person is having 0.5 to zero point 0.6 and I'm comfortable with it. 0.5 is the best. Neither it's too low nor it's too high. And for prophylaxis and maintenance, it's a good serum lithium level. Usually it is done with a dose of 400 to 800 milligrams per day. Very seldom to 1200 milligrams per day. Mostly 800 makes a very reasonable dose. But if the levels are high, 1.5 to 2, which again, if you are very enthusiastic, you have pushed up the lithium to 1200 to 1600 milligrams per day, very suddenly to control the mania, which we usually don't do. हम psychiatrists वैसे भी कोई बहुत ज़्यादा रिस्क नहीं लेते, हम बड़ा धीमे धीमे चलते हैं और इतने धीमे चलते हैं कि मरीज की बेचारी की जिंदगी जो है ना वो बैसाखियों पे महीनों चलती रहती है. So this is another reason why I believe that psychiatrists are very slow to treat. They start with sertraline 25 milligrams per day. 3 हफ्ते के बाद उसको 50 करेंगे, 3 हफ्ते के बाद उसको 75 करेंगे. भाई इतनी देर में तो बेचारा suicidal हो जाएगा, मरने मारने पे तुल जाएगा. So it's better to push up the drug quickly when you know that you have to achieve those levels. So I always encourage to do that. Again, recommended monitoring parameters for lithium. MCQ could be what are the laboratory investigations that are needed for the lithium levels. BMP, CBC, TSH, and other stuff. Sorry. And urine analysis, pregnancy test, of course, and ECG and cardiac history, counseling, serum lithium levels monitoring. Then you have to do some other test if needed according to the pathology. This is what it is. Well, this is lithium. So anybody, any question?
सर मेरा क्वेश्चन है
हाँ
कि आपने कहा कि प्रेगनेंसी और ब्रेस्ट फीडिंग में कॉन्ट्रा इंडिकेशन है लिथियम की क्योंकि वो ब्रेस्ट मिल्क में स्क्रीट होता है. तो क्वेश्चन मेरा ये है कि अगर एक पेशेंट लिथियम पे स्टेबल है एंड इफ शी गेट्स प्रेग्नेंट तो हम डिसकंटिन्यू कर देंगे फिर?
Oh yes, we have to counsel the patient, and if patient gets if usually this is another problem in Pakistan, the patients do come and tell you, okay, Dr. Saab, I was taking lithium and now I'm pregnant, and you are stuck because it's been either 2 months
Exactly.
or 3 months and 4 months, and you are confused. What the heck? So this is what the problem is. Unfortunately, this is a complicated problem. This is a very complicated, risky situation. And we have to go for fetal monitoring. And if you find that there is some anomaly in the fetus, then of course, therapeutic abortion is recommended. This is lack of education, and on part of the psychiatrist, it's unfortunately a mistake as well. We have to tell it to the patient that if you are taking lithium, you cannot conceive. Full stop. There is no second thought about it. If you are pregnant, lithium will be discontinued. You have to take the responsibility of having a mood fluctuation and relapse of the bipolar disorder if you conceive and you are on a lithium therapy. So if you make sure that your patient understands this, there is no complication. But if patient get conceived and she's on lithium, either you have to stop it, taper it off, or, well, taper it off very quickly, of course, but that is risky because lithium cannot be stopped suddenly. But if there is a life-threatening situation, like if a patient comes to you and she says that I'm 2 months pregnant and I'm on lithium, of course you have to stop it. And then you have to manage her in inpatient psychiatry to make sure that the withdrawal of the lithium effects should not come in, the child is safe, the mother is safe, and you have to take all those precautions which are needed. But yes, you have to stop it in both the situations. Breastfeeding, though, of course, by the time, if the patient is breastfeeding, I will never start her on lithium. I will wait till the time the breastfeeding is completed. So I don't want to take those risks. No, not at all. G. Manur, you wanted to ask a question. You raised a hand. Go ahead.
सर मेरी इसी क्वेश्चन में कंटिन्यूएशन है आगे, जैसा आपने बताया पेशेंट हमारे पास आए फॉर एग्जांपल 4th-5th मंथ ऑफ प्रेगनेंसी पे और वो लिथियम पे ऑलरेडी है और वो लेती रही हैं और हम उनका फीटल एनॉमली टेस्ट भी करवाते हैं और वो ठीक आता है, फिर भी उसे बंद करने की जरूरत है या
Yes.
फिर हम चलने देंगे?
नहीं, लिथियम फिर भी बंद करनी है, स्लोली करनी है, लेकिन बंद करनी है, बिकॉज as I mentioned in my presentations, lithium has a very complex mechanism of action. It's not very simple as what is told to us by our seniors कि जी सोडियम को रिप्लेस कर देती है और मेम्ब्रेन स्टेबलाइजिंग फैक्टर, इसका बहुत सारी जगहों पे इम्पैक्ट है, खासतौर पे न्यूरोलॉजिकल इम्पैक्ट है, स्पेशली जैसे बात हुई थी कि अल्जाइमर्स डिमेंशिया में दी जा सकती है क्योंकि वर्किंग मेमोरी पे काम करती है. सो इसके वो जो IPP pays or IM pays, fetus may, all those things are actually developing, and lithium will stop that process or alter that process. So the long-term consequences in the child could be complicated. Even if the physical morbidity like limb deformity or facial deformity is not seen, there may be some psychological or other consequences later in life. So it's always recommended that if a person conceives, the lithium should be discontinued, even if there is no fetal anomaly, because we don't want to see the complications in the long term. No. So it should be stopped. आप कह सकते हैं, मैं कह नहीं रहा, लेकिन कह सकते हैं कि ये एब्सोल्यूट कॉन्ट्राइंडिकेशन है लिथियम की, प्रेगनेंसी एंड ब्रेस्ट फीडिंग. रीनल डिजीज भी एब्सोल्यूट कॉन्ट्राइंडिकेशन है, बिकॉज रीनल डिजीज के पेशेंट्स को भी हम लिथियम नहीं दे सके. कार्डिक पेशेंट्स, आई विल डेफिनेटली थिंक अबाउट इट, मे बी आई विल गिव, मे बी आई विल नॉट. If I think that the cardiac problems are not so significant and stable and the patient can tolerate the lithium, I will definitely try to go for it. But usually, yes, we don't give it to the people. Best age of starting lithium in bipolar patients is between 40 to 60. Earlier than that, well, young people, definitely male, I won't mind because it is a very good drug. In females, if they are not actually, if they have completed their family or if they are not willing to have a family, that is a good drug. Right? Any other question? Anybody?
सर
No?
एक कमेंट बॉक्स में भी क्वेश्चन है आई थिंक.
Question आया. Okay. Kindly explain verbal and non-verbal. मैंने जैसे स्लाइड में दोबारा दिखा देता हूँ, वर्बल एंड नॉन वर्बल मेमोरी वाली. आई नो इट्स यू वोंट बी वेरी हैप्पी विद इट, it's very difficult to understand, but I will just try to show you the slide again so that you'll be able to understand. You see, this is how it is. It increases PGSK3B, BDNF, autophagy, mTOR, IMM and inflammation are reduced. Working memory, where is it? Where is it? Where is it? Okay, let me go back. Where is working memory? Okay. Okay, this one. So in amygdala and hippocampus and cingulate gyrus, which are actually the three main sites for these four problems, verbal problems, processing. Verbal memory, non-verbal memory is usually in amygdala, and executive functionings in hippocampus, and cingulate gyrus, processing speed and working memory. This area, lithium goes, and then lithium increases GABA levels, upregulates GABA receptors, and when we give NMDA receptor like glutamate is enhanced, then there is excitation of the neurons in these areas, and the working memory improves. Got the answer?
सर मेरा एक और क्वेश्चन है क्लिनिकली, जैसे वो प्रेगनेंसी वाला था, कि अब फर्ज करें हमने 400 मिलीग्राम्स ऑफ लिथियम स्टार्ट किया है और हमने लेवल्स करवाए हैं, तो वो थेराप्यूटिक लेवल्स अचीव हो गए हैं,
Okay.
ठीक है, लेकिन पेशेंट की जो कंडीशन है वो इम्प्रूव नहीं हुई, तो फिर क्या हमने लिथियम को फर्दर बढ़ाना है, जैसे 400 से बढ़ाना है, क्योंकि थेराप्यूटिक लेवल्स में तो उसके लेवल्स आ गए हैं, तो फिर ये हम लिथियम को
थेराप्यूटिक
स्विच कर
लेवल्स
देंगे कि फेलियर है?
0.6 से 1 पे लेवल्स पे अचीव हो गए, ठीक है, और आपने देखा कि ये लिथियम मैंने 400 मिलीग्राम्स की और इसी पे 0.6 to 1 मिलीमोल्स पर लीटर अचीव हो गया और पेशेंट ठीक नहीं हो रहा। सो आप फिर ये देखें कि पेशेंट क्यों ठीक नहीं हो रहा। अब इसमें मल्टीपल इश्यूज हैं, ये क्लिनिकल जजमेंट है, क्लिनिकल कॉल है। लाइक एनी अदर ड्रग, there is a possibility that lithium may not work. It's not a magic drug that it will work in every patient and make sure that every patient gets better with lithium and no bipolar disorder. It's not like that. If it suits majority of the people. If it won't suit, of course, there won't be a thing. But the point is that if you have seen that there are 400 milligrams, the therapeutic levels are achieved, and the patient is not symptom free, what symptoms you are addressing? If you are giving it for maintenance therapy in a bipolar disorder remission or prophylaxis, then of course you won't be able to understand it till the time the patient comes back with another episode. Yes, it happens very frequently, multiple times with me. I have given a lithium to a patient. They were stable. They went back. After 6 months, they came back and they said they haven't missed the medication. Their serum lithium levels were okay, and they still had a bipolar situation. Manic episode ho gaya, ya depressive episode ho gaya. In that kind of a situation, my choice is to add the second mood stabilizer. If she's a female, I prefer lamotrigine, and if he is a male, then I prefer valproate or any other. Now, there are other mood stabilizers, and there are a number of studies which suggest that single mood stabilizer may not be able to achieve remission in bipolar disorder. So you have to combine mood stabilizers. And this presentation I've already done, that mood stabilize, you may need to combine them in bipolar patients. So there are some of my patients, and you people are best judged because you know that. I give combination of a mood stabilizer. So the patient is on lithium, valproate, and lacosamide, 3 mood stabilizers. Or patient is on lithium, brevicitam, and lacosamide. Or patient is on lithium, lamotrigine, and lacosamide. So ultimate goal is to achieve remission, because in bipolar disorder, this is most difficult situation that people have acute manic episode that can be managed, depressive episode that can be managed. But the cyclical pattern in the future, that is most important thing that needs to be managed. और मैं अक्सर अपने मरीजों को यही स्टेटमेंट देता हूं कि ये एपिसोड तो 2-3 महीने में ठीक हो जाएगा, हम कर लेंगे। टारगेट ये है कि ये दोबारा बीमारी ना आए। You might have heard this sentence from me. to multiple patients. Target ये है कि बीमारी दोबारा ना आए. That is crucial, actually. Having a relapse is a crucial situation. We have to stop that. Got it?
तो ये तो सारी बात मुझे समझ आ गई. मैं बेसिकली ये पूछना चाह रहा था कि एक दफा जब थेराप्यूटिक लेवल्स अचीव हो गए हैं उसके बाद फिर हम ऐड कर सकते हैं, रीअसेस कर सकते हैं, लेकिन फर्दर लिथियम डोज एस्केलेशन का तो फिर रोल नहीं ना है कि हम कहेंगे यार
No.
अभी भी सिम्टम्स इंप्रूव नहीं हो रहे तो 400 से 800 कर दो, अगर थेराप्यूटिक लेवल 400 पे ही आ गए.
थेराप्यूटिक लेवल्स अगर आपने अचीव कर लिए आपको डोज नहीं बढ़ानी, वो तो टॉक्सिक में चला जाएगा. अगर
ठीक
आपके
है सर, मैं
थेराप्यूटिक
यही
लेवल
पूछ रहा था.
400 मिलीग्राम्स पे 0.8 आ रहे हैं और आप उसको 600 करते हैं तो हो सकता है वो 1.2 से ऊपर चला जाए. फायदा क्या है? यूजुअली ऐसा होता नहीं है वैसे. आमतौर पे 800 मिलीग्राम्स तक थेराप्यूटिक लेवल्स जो है ना वो उसी तरह से ही रहते हैं, बिटवीन एनीथिंग बिटवीन 0.4 and 0.8. Very seldom I have seen people taking 1200 milligrams and their levels are still low, 0.6 or 0.5. So it varies from person to person. Their metabolism, their excretion rate, their kidneys, so many things. But you have to again monitor and manage. Right?